Hey everyone, and a big welcome to all you pathology trainees out there. We've all had that moment, right? You're staring down the microscope at a marrow that's just jam-packed with plasma cells, and you're thinking, okay, how do I build the perfect report for this? Well, today, we're going to demystify that whole process. We're doing a practical walkthrough of the CAP protocol for plasma cell malignancies. It's an absolutely critical tool that's going to bring so much clarity and consistency to your daily sign-out. So, just so we're all on the same page, everything we're talking about today is straight from the official CAP protocol, version 1.0.0.1. You should really think of this as the gold standard. It's the official playbook designed to make sure all of our reports are consistent, complete, and, most importantly, clinically useful, no matter where we're practicing. And this is the million-dollar question, isn't it? The world of plasma cell disorders is, well, it's complex. So how do we bring order to that chaos? The answer is standardized reporting. This protocol gives us the framework we need to turn all that complexity into real diagnostic clarity, which gives our clinical colleagues the information they need to act with confidence. Okay, here's our game plan. We're going to start with the why behind this whole protocol. Then we'll dive right into the key diagnostic categories. After that, we'll get into the ancillary tests that really sharpen our diagnoses. And finally, we'll put it all together to see how you build a clear, super impactful report.
So, let's start with the basics. What is this protocol actually for, and why is it so darn important?
The first thing you've got to appreciate here is just how broad the scope is. This protocol isn't just for bone marrow, It applies to any sample site. And it creates a single, standardized language for everything from multiple myeloma to the much rarer deposition diseases, and it's all grounded in the WHO 5th edition. What that means is a pathologist in one hospital is communicating the exact same critical information as a pathologist clear across the country. That's huge.
All right, let's get into the bread and butter of this whole topic, the plasma cell neoplasms themselves. This is where we have to make some of the most critical calls in our diagnoses.
This right here is a major fork in the road. You see, both of these conditions can have a ton of clonal plasma cells. The defining difference, the real line in the sand, is whether or not myeloma-defining events are present. Smoldering myeloma is kind of like a watch-and-wait situation, but multiple myeloma, that demands action. So what exactly are these events? Here they are. First, you've got the classic clinical stuff, the end organ damage we all know from the acronym CRAB. That's high calcium, renal failure, anemia, and bone lesions. But what's really, really critical for a modern diagnosis are these next three biomarkers: a bone marrow that's just stuffed with over 60% plasma cells, a free light chain ratio over 100, or specific findings on an MRI. The key takeaway here is that just one of these, even without any CRAB symptoms, is now enough to call it multiple myeloma. And that's a game changer because it allows for much earlier treatment. Think of this table as your go-to cheat sheet. Just notice the key cutoffs: less than 10% marrow involvement for a plasmacytoma versus 10% or more for both smoldering and multiple myeloma, and that's where those defining events become the big separator. Oh, and here's a crucial update from the WHO 5th edition you don't want to miss. Remember to check the peripheral blood. The threshold for plasma cell leukemia is now just 5% circulating plasma cells.
All right, let's switch gears for a minute. Not all plasma cell disorders are about the cells causing problems. Sometimes it's about the abnormal proteins they're churning out and where those proteins end up.
So first up is AL amyloidosis. The two key words to lock into your brain here are extracellular fibrils, okay? These are basically misfolded immunoglobulin light chains that clump together into these insoluble structures, and they just gum up the works in organs like the heart and the kidneys. Then we have its cousin, monoclonal immunoglobulin deposition disease, or MIDD for short. This is also about protein piling up, but there's a huge distinction. These deposits are not amyloid. They don't form those signature fibrils. It's a totally different process, which means we need different tools to spot it. So here's how we tell them apart down the scope. Amyloid has that classic amorphous, kind of pink, cracked look on an H&E stain. But the definitive test is the Congo red stain. When you polarize it, you see that beautiful, classic apple green birefringence. MIDD, on the other hand, is Congo red negative. This means that Congo red stain is your first and honestly your most important tool for figuring out which path you're on. Okay, let's move on to a much rarer but I think equally fascinating group of disorders, the heavy chain diseases.
The molecular story here is pretty unique. What's happening is the neoplastic cells are producing these defective, shortened heavy chains that can't properly link up with light chains, and this leads to these isolated, abnormal heavy chains just getting secreted into the blood and tissues. They come in 3 main flavors, named for the heavy chain that's involved. Mu heavy chain disease often looks a lot like CLL, and it even has these characteristic vacuolated plasma cells. Gamma can be more diverse, and alpha is actually considered a variant of malt lymphoma, which we often find in the GI tract. The key is to recognize what they can mimic.
Okay, so we've covered the morphology and the major diagnoses. Now, how do we confirm them? And how do we get that crucial prognostic data that our oncologists are waiting for? Let's open up the toolkit.
I want you to think of this as a logical workflow, a step-by-step investigation. We usually start with IHC to confirm we've got plasma cells and to prove they're clonal. Flow cytometry gives us a more sensitive, detailed look at their immunophenotype. Then we move into genetics, karyotyping for the big picture changes, FISH for specific high-risk abnormalities, and more next-gen sequencing for a really deep molecular dive.
Now, this slide is where our reports have a direct, massive impact on patient care. The CAP protocol says we have to comment on these specific FISH abnormalities. And why is that? Because findings like a T414 translocation or a 17p deletion are incredibly powerful prognostic markers that directly influence what treatment a patient gets. Your FISH report isn't just data, it's a roadmap for patient management.
You know, this really gets to the heart of why we do all these tests. Each one of these genetic abnormalities, it gives us a window right into the tumor's biology. It tells a story about how aggressive it is, what's driving it, and even what its potential vulnerabilities are. Our job is to translate that genetic story for the clinical team.
Finally, let's bring it all home and talk about the final product, the report itself. We've gathered all this evidence from morphology, from our ancillary studies. Now it is time to put it all together. I love this quote from the protocol because it nails it. Diagnosis relies on integration. We don't make these calls in a vacuum. Our pathologic findings, like the plasma cell percentage or the FISH results, they have to be integrated with the clinical picture, the patient's serum calcium, their creatinine levels. Our report is one critical piece of a much larger diagnostic puzzle. And please, never forget this. A clear, concise, well-structured report that uses the CAP protocol, it isn't just good practice. It is the bedrock upon which every single clinical decision that follows is built. From the initial diagnosis, to the treatment plan, to the prognosis, it all starts with your words. So I'm going to leave you with this question to think about. The very next time you get a plasma cell case, think about this framework. Ask yourself, how can you use this standardized approach to make your diagnosis more precise, your report more impactful, and your contribution to patient care even greater? Thanks so much for joining me.